Good morning, everyone, and welcome to this webinar. My name is Paula Matesanz, and I'm here with David Herrera. We are both colleagues from the University Complutense of Madrid. And before we dive into our presentation, I would like to take a moment just to let you know how everything is going to work. Now we are speaking English, but if you want to change the language to Spanish, you can press the lower bar in the screen, and it will change. It has a simultaneous interpretation. And you can see also a box for the Q&As. And even though we'll try to be as easy to understand as possible, if you have any doubt, don't hesitate to write it down in the Q&As box, and we'll do our best at the end of the presentation to explain or to make any additional comments needed. So now, and before really going through our presentation, I would like to take a moment to express my gratitude to Kenview for inviting us to participate in this event. I truly appreciate the opportunity to share insights on the use of antiseptics in periodontal care with the audience and with David Herrera. And it's inspiring to see Kenview's commitment to promote knowledge. I really thank you for your dedication. So now let's get started. David? Again. Next. So in an attempt to make it easy to follow, we will move from the lowest to the highest knowledge, starting from the diagnosis of the different conditions or situations of the periodontium to their management, as it was defined in the last classification of periodontal and peri-implant diseases. We can find three main situations in periodontal tissues, which are health, gingivitis, and periodontitis. Each of these conditions can be related to a level of prevention of periodontal disease and eventually to a specific treatment. Next, please. Historically, health, not only in the periodontium, but in every part of the body, was defined as the absence of disease. The lack of symptoms and signs of disease meant that you were healthy. Nevertheless, some years ago, the World Health Organization decided that this meaning was not correct anymore, and that health should be referred to a condition of well-being with complete functional capacities and proper aesthetics. This was understood by the periodontal scientific community, and the first definition of health following these rules was incorporated to the last classification of periodontal and peri-implant diseases. In this level of diagnosis, there would be no need to implement any level of treatment, as there is no disease. And what we could develop at this level would be the primary prevention of any kind of periodontal disease, the prevention of gingivitis and periodontitis. Next. The following situation we could encounter would be gingivitis, which is a reversible condition characterized by the presence of gingival inflammation of periodontal tissues. And it's very easily recognized because of the bleeding gums. At this point, we could develop strategies for controlling the disease and return to the health state. But by doing this, we will be preventing as well the onset of periodontitis, as it is assumed that both diseases, gingivitis and periodontitis, are a kind of continuum of the same situation, the same condition. Therefore, here we have a treating level, the treatment of gingivitis, but another level of prevention, which is the primary prevention of periodontitis. So now next. If the evolution of periodontal diseases continue, we would now face the following condition, which is periodontitis, which is an irreversible condition that can eventually lead to tooth loss, to functional and aesthetic impairment, and also to some relation with other problems of general health due to its inflammatory condition. In this level of disease, we can develop therapeutic strategies for controlling the problem, but once treated or arrested, we could develop another level of prevention, which is the secondary prevention, the one aimed to prevent the relapse of periodontitis. So now, if we move to the following the slide and we try to summarize all this that has been said, we have these 3 levels of health or disease that go from health to periodontitis. In each of them, we can implement a level of prevention or a level of treatment. So we'll now start with the following slide, if you want to, yes, which is the treatment. We'll start by the treatment by the active treatment of these diseases. The first one is gingivitis. Most of the comments we will make about the use of antiseptics in regards to the treatment of gingivitis are based on the workshop held in 2016, and in the following slide, the consensus and the systematic review held in this workshop of the European Federation of Periodontology, in which David took part. So as we have him today with us, I'm sure he can tell us a lot about it. Hello, David.
Hello, hola. How are you, Paula? Thank you. I also thank SEPA and Kenview for inviting me to participate in this very interesting, I believe, session. And following the question made by Paula, we are dealing now with the treatment of gingivitis. And for the treatment of gingivitis, we have solid evidence coming from the studies that we call oral hygiene randomized clinical trials, home use randomized clinical trials. There is a rule in which you say that an agent is effective if at least 2 randomized clinical trials of at least 6 months of duration demonstrate an impact on the biofilm levels or on the gingival inflammation level. And this is what we did in the systematic review that you can see in your screen that was published in 2015, and that was used as the basis for the discussion in the European workshop on prevention of peri-implant and periodontal diseases. We searched for all those 6 months randomized clinical trials with a placebo control or a negative control. And after the search, we were able to identify 87 different studies. Of them, 65 were included in the meta-analysis, and we were able to perform more than 120 meta-analyses. The most important meta-analysis is the one that you can see here is the impact of all the agents, even formulated in toothpaste or in mouth rinses, for the Lu and Silkness Gingival Index. And everything that you see on your left side means that it is in favor of the test agent, and everything which is on the right of the 0 means that the placebo worked better. And as you can see, most of these studies suggested a positive benefit of mouth rinses, different mouth rinses, and toothpaste. This is for gingival inflammation, and a similar forest plot was prepared for the plaque index, in this case, the Tureski plaque index, and many of these studies demonstrated a positive effect on plaque and gingival inflammation, as you can see. But not all the products or all the agents were actually similarly effective, and we were able to produce this table, which is a very busy table, but I will help you to go through it, in which we identify the agents that had solid evidence of efficacy in terms of inflammation and plaque. And those agents were mouth rinses with cetylpyridinium chloride, mouth rinses with chlorhexidine, mouth rinses with essential oils, and mouth rinses with a combination of amine and stannous chloride. And for toothpaste, the ones that provide evidence based on our meta-analysis and other systematic reviews, we were then toothpaste with chlorhexidine, toothpaste with a combination of triclosan and copolymer, and toothpaste with a combination of stannous chloride and sodium hexametaphosphate. Therefore, we have evidence that agents formulated in toothpaste or a mouth rinse are capable of controlling gingivitis, therefore they may have a role in the treatment of gingivitis. But I'm not sure if we have the evidence to support the use of these agents also in the treatment of periodontitis. So maybe Paula can explain to us if this role that we have seen may be positive for the treatment of gingivitis could be the same for the treatment of periodontitis.
Mm-hmm. Thank you, David. I hope everything is clear for you now up to this moment, and if it isn't, please write your questions in the Q&A box. So now we will move on to periodontitis treatment. I again have to say that this is the irreversible condition of the periodontum that fortunately can be treated, and some of the main complications derived from this disease can be prevented. So please, the next one. Yeah, here. So periodontitis, as we know it nowadays, was defined in this paper from 2018, in which periodontitis started to be classified according to different stages based on the complexity and the severity of the disease, and in 3 different grades, A, B, and C, related to the progression and the anticipated treatment response. So once this classification was published, the next step in the way for a proper management of this disease was the reduction of clinical practice guidelines that could clarify and specify how and why specific therapeutic strategies are developed and how they should be carried out by clinicians. So with these objectives in mind, 2 workshops were held in 2019 and 2021, the year between them. I know we were at home trying to not to die. So please, the next slide. What happened in the aforementioned meetings? So, many key opinion leaders met for 3 days. And those are 3 days of very hard working and tough thinking. And they came up with these 2 consensus documents in which treatment of the different stages of periodontitis is explained and protocolized. So here you have the picture of the first one, the second one, yes. And now, according to these guidelines, periodontal treatment consists of a sequence of procedures that must be developed in a specific order. You cannot skip one of the steps and move to the following one. So you have to move from the diagnosis and treatment planning to 4 separated steps of treatment. So in the following one, in agreement with what was designed, periodontal treatment can be described as a kind of a ladder in which we as professionals have to climb to a different step depending on the complexity and the severity of the case. And sometimes you can skip the 3rd step, which is the surgical one, but you have to go one by one. And all the patients, no matter the severity of the problem at the initial stages, have to end in the SPC, which is the maintenance step that every patient has to be enrolled in this step for good. So each of these steps, if we go to the next slide, each of these steps encompass different interventions. They are regulated by multiple recommendations in which every aspect of therapy was evaluated during the workshop and analyzed, and all of them have a final positioning in favor or against, depending on the evidence behind it. So the first thing that was analyzed, and go to the next one, please, David. The first thing that was analyzed was the evidence behind it, but there were also other issues that were taken into consideration for the final recommendation. So please, can you elaborate a little bit more on this, please?
Of course, Paula, because this is the difference between a clinical practice guideline and the evidence-based concepts that we have followed for many years. So in the evidence-based medicine, most of the decisions are taken based on efficacy. Imagine that we have an intervention A provide 5 millimeters of probing pocket depth reduction, and then intervention B provide 2 millimeters of probing depth reduction. So when it comes on efficacy, it is clear if intervention A is better than intervention B. There's no doubt. But in a clinical practice guideline, we need to consider other factors. For example, we need to consider if the cost. So if the intervention E cost 1 million euros and the intervention B cost 2 euros, which one do you prefer? The one giving you 5 millimeters of efficacy or 2? And what about the patient preferences or feasibility? Imagine that to perform intervention A, you need a highly trained specialist that you only have one per country. While for intervention B, you can do it with any general dentist. So all these things are put together in order to make the decision about recommending or not a particular intervention. And this is analyzed in this way. So imagine that you have a lot of efficacy. So you say, okay, this is very efficacious. We recommend this recommendation. It's a strong recommendation, but then it's associated with a lot of side effects, high cost. It is not, patients will not look that. Then you can downgrade the recommendation from strong to normal, then to open recommendation, and even sometimes interventions which are highly efficacious can become not recommended due to, for example, to the side effects. And this is the perfect example of the systemic antimicrobials in the treatment of periodontitis. The efficacy is very high. The side effects in terms of bacterial resistance are very, very important. Therefore, at the end, instead of a strong recommendation in favor, we have a strong recommendation, a negative recommendation. So this is the way in which clinical practice guidelines are dealing with the recommendation.
So, yeah, thank you. So everything counts. It's not only what the result can achieve a specific strategy, but also these other things. So now, the next, please. Now, having understood what these recommendations mean, we have the intention to go over the different steps and see in which points the adjunctive use of antiseptics can contribute to the resolution or the control of periodontitis, as well as the prevention of its recurrence. So the first step is the step of risk factor control. It is necessary to activate patients' motivation if we want to promote the behavioral changes expected in this first moment of the therapy. And our interventions must be guided by this objective. But there's another intention in this first step, which is the control of gingival inflammation. And that will be achieved by means of professional mechanical removal of the supragingival biofilm and calculus, together with the elimination of local retentive factors. And everything must be done under the educational and preventive interventions through which patients can understand the level of cooperation required for disease management. So if these are the objectives, the following, please. It is unclear whether antiseptics should be a general recommendation for this initial step of the therapy. Nevertheless, as the control of gingival inflammation is a clear goal of this step 1, which is also shared with gingivitis treatment, as we previously said, we should probably have the same considerations as for the previously reviewed treatment of gingivitis. So this is a little bit of an inference, but it could be done. Antiseptics provide significant reductions in gingival indices. Therefore, antiseptics may represent a good option as adjunct to self-perform mechanical plaque control. Additionally, there is consistent evidence showing that the adjunctive use to mechanical plaque control of toothpastes or mouth rinses with specific active agents improve the reduction of plaque levels. So probably the use of antiseptics would fit in this first step of treatment, although it was not specifically analyzed during the workshop and in this clinical practice guideline. Now, if we move to the second step, of therapy, we will need to change our mindset and now forget about the behavioral changes and risk factor control, and now go for the active control of subgingival biofilm and calculus. This second step consists mainly in subgingival instrumentation and needs to be implemented in every patient with periodontitis. Nevertheless, in some situations, the additional use of local or systemic agents can be taken into consideration. In regards to antiseptics, if we move to the following slide, this question was not specifically addressed during the systematic reviews prepared for the workshop, but previously existing information regarding the adjunctive use of certain antiseptics worked for the decision on this recommendation, according to which, as you see now on your screens, the adjunctive use of some antiseptics in mouth rinses with mechanical scaling and root planning results in slight improvement of clinical outcomes. So this circumstance can probably benefit those patients with compromised medical status, for example, or cases with high levels of gingival inflammation. On the other hand, it is important that the most frequent side effects related to the use of these antiseptics, such as dental staining, for example, must be considered and warned to the patient in advance. In the following step, in the third step of therapy, David, there's something you can tell us?
Well, first thing, after step 1 and 2 of therapy in periodontitis patients, you need to do a reevaluation. This reevaluation is something that you will do between 4 to 12 weeks after the last session of gingival instrumentation. And then you evaluate the periodontal outcomes. You evaluate probing depth, bleeding improving. If you have already achieved the endpoints, then you can move to supportive periodontal care. You do not need to keep on working with active therapy, but if the endpoints have not been achieved, then you may need additional treatment. And this additional treatment is either re-instrumentation or periodontal surgeries. And these periodontal surgeries are especially necessary when you are dealing with intravonic defects or furcation lesions. So in this step 3, what could be the role of the antiseptic agents? Well, if we are dealing with re-instrumentation, as in step 2, we can use adjunctives. And among these adjunctives, antiseptics can be used. And there is evidence to support the use in the instrumentation. Also, antiseptics can be used during the healing period of after a periodontal surgery to promote healing or to avoid complication. And again, there is some evidence supporting this action. And finally, another suggestion could be that by using antiseptics adjunctive to periodontal surgery, the results in terms of periodontal outcomes could be improved. None of these indications was assessed in the clinical practice guideline for the treatment of periodontitis in stages 1 or 3, but indirect evidence and some direct evidence not presented could suggest that they could be useful. And we have mentioned already that whenever you have achieved the endpoints of therapy, you move to supportive periodontal care. So in supportive periodontal care, you have a primary objective, which is to avoid disease recurrence. It is somehow similar to the step 1 because most efforts will be done to control risk factors and to control supragingival biofilm. And you will have different approaches whenever you are dealing with high or low risk patients, or whenever you are dealing with periodontitis patients with a healthy periodont, reduced but healthy, or when you're dealing with patients with some levels of gingival inflammation. And those patients with gingival inflammation may require additional efforts in order to control the risk for recurrence. Again, in these higher risk patients, it can be considered the use of adjunctive therapies, as we can see. We, of course, include within supportive periodontal care the things that we do at the clinic, professional interventions, but also patient-based intervention in terms of risk factor control, supragingival biofilm control. You of course know that at every professional visit within the supported periodontal care program, we will do an evaluation of the systemic and periodontal health. We will reinforce oral hygiene instructions. We will motivate the patient to control risk factors and also to control supragingival biofilms, provide the professional mechanical plaque removal, and if we detect pockets, then we need to do localized subgingival instrumentation. So the role of antiseptic agents in this context of supportive periodontal care is actually included in one of the recommendations. Don't ask me why the computer is now getting crazy. I try to come back to the recommendation. Here it is. So there's a recommendation for patients in supportive periodontal care to help better in controlling gingival inflammation. We may consider adjunctives agents, and among these adjunctive agents, the only ones which has provided evidence of benefit are in antiseptics. So the guideline said they may be considered, and they may be considered is based in the fact that we have evidence that they may control gingival inflammation, and the studies demonstrate that the impact is similar in patients with gingival inflammation without periodontitis or with gingival inflammation with periodontitis. And in addition, we have very limited number of studies, to be honest, but we have some studies that have demonstrated that the use of some antiseptic agents can reduce the risk of disease progression in the future. We should, and the guideline specifically describe this, we should consider, in this may be considered, local factors and general factors. So general factors like the higher level of gingival inflammation, of the limitation, limited access for cleaning, or general factors like systemic factors, limited dexterity, frailty, everything. Many of these factors actually connect with the elderly population. So all these factors may be considered, may suggest that the patient will benefit from the use of these agents. And if we look at the agents, the guideline is identifying 3 specific agents formulated in toothpaste: chlorhexidine, triclosan copolymer, and stannous chloride, and 3 specific agents to be formulated in mouth rinses: chlorhexidine, essential oils, and cetylpyridinium chloride, but we will discuss that in more detail. So after going through all the steps that we have seen the possible role of antiseptic agents in step 1, we have seen the possible role in step 2, step 3. In step 4, we have just seen is where the guideline is providing more information. Paula, you may want to tell us, are they really useful overall, considering all the steps of therapy?
Yes, I've tried to summarize a little bit in this slide what we have said up to this point in regards to the use of antiseptics as adjuvants in the treatment of gingivitis and periodontitis. And I will give you just some key points on each of these different situations. First of all, in gingivitis, we have said that antiseptics help reducing gingival and plaque indices, so they can be considered as an adjunctive part of gingivitis treatment. In periodontitis, the treatment has been divided in 4 different steps that must be implemented one by one gradually. So probably the use of antiseptics must be analyzed separately. So in the first step, as it has much to do with gingivitis management or treatment, and as it is aimed in some degree with the control of gingival inflammation, similar messages than those related to gingivitis treatment can be applied in this first step. So therefore, antiseptics probably could be an aid for this first step of therapy. In step 2, there is a specific recommendation alluding the use of certain antiseptics as adjuvants to subgingival instrumentation based on the grounds of the additional benefits that they promote in the clinical outcomes. So antiseptics may be considered in this second step of treatment, especially in patients with a compromised general health. In step 3, the surgical step, when mechanical plaque control is limited, antiseptics in mouth rinses probably can represent an aid to promote healing. It has been shown that they promote some improvement in clinical outcomes. So despite past concerns about the negative effect that antiseptics were known to have on fibroblasts, it is not any longer a concern, and antiseptics can be considered in this third step of treatment. And last, in the SPC, or the fourth step, where the clinical practice guideline allocates more recommendations and messages related to the use of antiseptics, they can be considered in the prevention of the recurrence of periodontitis during maintenance, especially in the presence of local and systemic factors, as you mentioned, that make biofilm and inflammation control more difficult for patients, or in those in which the recurrence of periodontitis could have a more serious impact on their general health. So I hope that everybody is still alive and concentrated on what we are saying, because after reviewed all this part referred to periodontal treatment, active treatment, we are now moving to prevention. We are going to dedicate a time to see if antiseptics have any interest, or if they can be of any use in the prevention of periodontal diseases. As we already mentioned, there are different levels of prevention associated with the different conditions of periodontal health and disease, and we'll see what we can do in each of this level. So as we did, the next please, as we did with the clinical practice guidelines, we have tried to get our conclusions from the evidence published, and in regards to prevention, most of them were based on the European Workshop on Prevention, in which some bullet points were published. First, that mechanical plaque control should be the focus of preventive periodontal therapy. Professional guidance in oral hygiene is vital and is effective in reducing plaque levels in gingival inflammation. Conscientious manual toothbrushing reduces gingivitis, that's for sure. Daily interproximal cleaning is essential for maintaining interproximal gingival health. And as an adjunct to mechanical plaque removal, mouth rinses offer significant benefits in the management of gingivitis, as do certain chemical agents in dentifrices or toothpastes. The use of mouth rinse requires additional patient adherence, has cost and environmental implications, and should be considered on a case-by-case basis. So with this in mind, let's move to the following slide. Okay, so down again, David, what can you tell us about the evidence behind all these recommendations?
Okay, so now we are in the prevention, and for the prevention, as we have explained at the beginning, but very briefly, we have some regulations. There are some rules. So the American Dental Association and the Food and Drug Administration, for example, they tell us what you need to demonstrate in order for an agent to say that it is effective in the prevention of gingival inflammation. So FDA, for example, they have category 1, category 2, and category 3, and gave category 1 to those which are safe and effective. And for anti-gingivitis agents, although this is changing, so for those agents that demonstrate prevention, efficacy in the prevention of gingivitis, they need or they request at least 2 independent home use randomized clinical trials. And this is what we have presented previously. So we have a lot of products, we have a lot of agents, but only a very limited list, as we have seen before, has actually provided evidence derived from at least 2 randomized clinical trials. And these are probably the list of products. So there's just 7 agents. 5 of them formulated in mouth rinses, 2 of them are formulated in dentifrice and toothpaste, and they have the first 5 solid and convincing evidence on the impact of gingivitis. The 2 on the bottom will need will request some additional information, but they are also probably anti-gingivitis agents. So one aspect to decide which of these agents, which has demonstrated efficacy, we are going to choose is the adverse event. So we all know that these products are associated with some problems. Some of them or many of them may produce staining. The one which produce more staining is chlorhexidine, but also those with alcohol may have some problems, or the Delmopinol mouth rinse is associated with the numbing of the mucosa, or triclosan with environmental problems that has actually made its use less popular every year. So there's one reason to select the agent, which could be the adverse events, but there are other reasons, and one of them would be efficacy. When we try to compare these agents in terms of efficacy, it's very difficult because we have very limited information in terms of direct comparison. So we like to know if chlorhexidine is better or than essential oils or than triclosan and copolymer, but there are very few studies with direct comparison between products. So this is the reason why some years ago in our research group led by Dr. Elena Figuero, we decided to do an analysis which is called network meta-analysis. And what we do is a mathematical process in which we can compare 2 products by means of a common placebo. So if you have a study which has compared the efficacy of stannous fluoride versus placebo, and you have another study which has compared the efficacy of triclosan copolymer versus placebo, if a number of things are fulfilled, a number of prerequisites are fulfilled, you can think that you can compare triclosan copolymer and stannous fluoride. And this is what it is depicted in this figure, showing that the differences between triclosan copolymer and the placebo, between stannous fluoride and the placebo, and then the difference, the inferred difference between stannous fluoride and triclosan copolymer toothpaste. This is with the plaque index, the Turek plaque index for toothpaste, and we see how 2 products that we have already mentioned, dentifrices, toothpaste with stannous fluoride and triclosan copolymer. And if we move to the mouth rinses here, we clearly see that the efficacy is higher for essential oils, acetylpyridinium chloride, and chlorhexidine mouth rinses. And as I tell you, we do these comparisons assuming that the placebos are identical. So if you compare essential oils mouth rinse with a placebo and acetylpyridinium chloride mouth rinse with a placebo, then you can compare both indirectly. We published in 2016 the analysis for the plaque index, and some years later we did the same, but with the gingival indices, which was a little bit more complicated because there are more different indices in the studies, and it's more difficult to analyze. But again, if you look at the results for toothpaste, dentifrice, toothpaste with stannous fluoride and triclosan copolymer provide better effects, and with mouth rinses, we have also similar results. And the products that were highlighted were essential oils, acetylpyridinium chloride, and chlorhexidine. Based on these 2 studies and the systematic review that I presented at the beginning by Serrano and co-workers, and the specific systematic review that was prepared for the workshop to develop the guideline by Figuero and co-workers in 2020, the guideline is selecting a number of agents, which are, when it comes to toothpaste, chlorhexidine, but is very limited availability in the market right now, triclosan copolymer, which is not in the market anymore due to the problems, the environmental problems of triclosan, and stannous fluoride. And if we look at the mouth rinses, again, chlorhexidine, essential oils are the ones which has demonstrated the highest impact on biofilm levels for gingival inflammation, essential oils, chlorhexidine, and acetylpyridinium chloride. And that is, again, the reason why these were the products suggested in the clinical practice guideline, although this was specific for patients in supportive periodontal care. When selecting the agent, there's always a very important question, which could be the ideal delivery format. So are we recommending mouth rinse, or are we recommending a toothpaste? Well, it is not easy, but the first thing we need to understand is that not all the agents are formulated in both formats. So if you want to recommend essential oils, you will need to use mouth rinse. And if you want to recommend stannous fluoride, it is the delivery format, the appropriate delivery format is identified. And also consider here in this graphic is depicting it very clearly that chlorhexidine is much more effective than all the other agents. Second in list will be mouth rinses with essential oils, then the toothpaste with triclosan copolymer and stannous fluoride, and with very similar impact acetylpyridinium chloride and amine stannous fluoride mouth rinses. Another thing that we need to understand is that for an agent to be delivered, the mouth rinse seems to be always more, will provide always a better or more favorable pharmacodynamic. So it looks like, with all the doubts that I have expressed before, and the association between specific agents with a specific delivery formats, it looks that mouth rinses could provide a better distribution rather than as when they are compared with the toothpaste. Although this is valid when we want to deliver a specific agent. The benefit with the toothpaste is that you are going to use a toothpaste anyway. So you may prefer to use a toothpaste which is already providing an antiseptic impact. So I think after what we have discussed, we have some evidence that may give antiseptic agents a role in the prevention of periodontal diseases. What's your opinion, Dr. Matesanz? Could you summarize those findings?
Yes, I'll try to. So there is.
Well, let me. Sorry, Paula, because I forgot to say something which is maybe important, which is we assume all this conclusion based on the impact of gingival inflammation, but we have very limited information about the true outcome, which is, are these agents preventing periodontitis? And we don't have direct information when it comes to primary prevention, as Paula said before, but we have some direct evidence when it comes to recurrence of disease, to the prevention of recurrence. And there are at least two studies, long-term studies, in which antiseptic agents has demonstrated that their use will be associated to a lower risk of recurrence. So in my mind, if I can ask for something before Paula make the conclusion about the role of antiseptic agents in the prevention of periodontal diseases, my request for the future is that the products should be evaluated in terms not only of control of gingival inflammation, but also on controlling the development or the recurrence of periodontitis. And my apologies for interrupting, Paula.
It's okay. What I was going to say is that as I did in the part of the treatment, I will try to summarize this prevention part. First of all, in regards to the prevention of gingivitis, there is no evidence that antiseptics help in the prevention of gingivitis. And of course, all the side effects must be taken into consideration on the cost and the environmental impact. But there is a point in the use of antiseptics as part of the prevention of the onset of periodontitis and the recurrence of periodontitis. First of all, they help reducing plaque and gingival indices. And this is the rationale for the choice in gingivitis control. So in the assumption that gingivitis and periodontitis are a continuum of the same disease, it could be inferred that the management of gingivitis could be considered a strategy for preventing the risk of developing periodontitis. And apart from that, the last conclusion of this part is that there is little, although statistically significant, evidence and clinically relevant information that they can help preventing the recurrence in SPC patients. Therefore, they can work for the secondary prevention of periodontitis. So now let's move on to the final and overall conclusions. First of all, the use of specific oral antiseptics, adjunctive to mechanical biofilm control, are effective in reducing gingival inflammation and plaque levels, something that has been repeated multiple times during this presentation. Antiseptics can effectively help in the treatment of gingivitis and periodontitis and in the prevention of periodontitis recurrence. We have said that they can be considered in the different steps of periodontitis treatment, in the treatment of gingivitis, and at different levels of prevention of periodontal diseases. Antiseptics have a safety profile, although side effects can appear with their use. Some concerns regarding the use of antiseptics in specific groups of patients may be considered, such as children under 6 years old or patients without deglutition control, also pregnant and lactating women, and alcohol abusers. Nevertheless, manufacturers' indications must be always followed. And although some concern was raised some time ago about the use of alcohol-containing antiseptics in smokers, the evidence does not support any possible association between the use of mouth rinses and the augmented risk of some cancers in smokers. Although the general population could benefit from the adjuvant use of antiseptics, it is essential to identify those subjects that will benefit most, considering both local and systemic factors. When we talk about local factors, we mean all those situations within the mouth that avoid proper biofilm control, such as inadequate accessibility for cleaning, for example, with tooth crowding or overhanging restorations, for example. Also anatomical factors that may act as plaque retentive factors, as root concavities and enamel pearls or radicular grooves. And some other situations, such as patients with dental implants, in which the niches of biofilm proliferate and may represent a risk both for the periodontal tissues, but also for the peri-implant tissues. Also in this chapter, we mentioned patients with high levels of gingival inflammation related to low plaque levels, in which the use of antiseptics may be an aid. And there are also general factors that will help professionals identify the ideal cases for recommending antiseptics. For example, those cases in which the general health status of the patient is delicate, especially if there is a certain degree of immune compromise or a systemic condition that can be related to periodontal condition, as for example, diabetes, or cases of frailty or elderly patients or patients with limited dexterity, whether temporary or permanent, or low levels of motivation. As it was mentioned in the first step of periodontal therapy, one of our goals is to motivate our patients in an attempt to improve their engagement, and the reduction in plaque and inflammation might work in this direction. So I hope we have done our best to make it clear for all of you, and I don't know if you have any questions. Let's see if there's any question in the Q&A's box. Thank you very much for your attention. I think you have to stop sharing. Okay, let's see. Okay, something that is here, it says, should mouthwashes be considered as part of the primary prevention daily self-care routine for prevention of gingivitis in diabetic patients? David, would you like to answer this?
Well, it's a very good question. If it is a prevention of gingivitis in patients with diabetes, it's more probably referring to type 1 diabetes because that be in populations in young people. And I don't think we have any evidence to suggest that this could be routinely used. So I guess that we can use the terminology of the clinical practice guideline. I guess that this has to be considered, may be considered case by case. I don't think we have evidence or direct or indirect evidence to make a strong recommendation of this. So I would suggest that, of course, if they have diabetes, they should visit periodically the dentist, and during those visits, the risk assessment should be evaluated, and the need of additional elements to control supragingival biofilms and gingival inflammation may be considered.
And more or less in the same direction as this first question, there's another one asking us whether, if given the global aging population where dexterity is likely to become more of an issue, should antimicrobial mouthwashes be considered an integral adjunctive measure for periodontal health? Again, I think the answer would be more or less related to the previous one, because for sure in this circumstance, in the case, as it was already mentioned, in the case of having a poor dexterity, probably will have this general recommendation for the use of the antiseptics, or a general indication, we could say. But for sure, every situation should be taken into the analysis one by one, not in a general, with a general answer, because the guideline is quite specific on that, both this last guideline, the clinical practice one, but also the previous that we showed, the one related to the workshop on prevention, in which this is something that is clearly said, every case has to be analyzed independently. So for sure, dexterity, the low dexterity, the poor dexterity is one of the indications, but you should take all the context into account. There's another question written in Spanish that says, why wouldn't we use, and I don't know if he or she means antiseptics or antibiotics from the first step, if we talk about the time and the motivation part. I don't know if this person means the antiseptics or the antibiotics. I don't know.
Yeah, it's not clear. If it's antibiotics, it doesn't make sense, because step one, we need to do subgingival instrumentation if we want to use systemic antibiotics, while antiseptics in step one are used to improve the results of supragingival biofilm control. So it will depend again on the condition of the patient. So since step 1 and 2 are mixed, sometimes this is not an easy to answer question if what would be the role, but sometimes the step 1 is done much ahead of step 2, and then in those cases, then antiseptics may have a role. But maybe the next question that is addressed to you, actually, it is about the probiotics instead of antiseptic agents, and I can answer that question because I just made a review on the issue, and it was included in the guidelines. So when the antiseptics, the recommendation says antiseptics may be considered, probiotics were assessed also as adjunctives in the supportive care, and we do not have yet evidence to support the use of probiotics the same way that we do for antiseptics. Maybe in the future, because the approach is very interesting, but for now, the trying to answer can replace the answer is today, no. In the future, it may be.
They are also asking us the time during which to use antiseptics so as to prevent the side effects, and this is something inherent to the use of these effective products, because the more effective it is, the more side effects that it generates. And probably what you should do always is follow manufacturers' advice. for the best result of derived from the use of the antiseptic. Chlorhexidine is usually recommended to be used for not more than 7 days in a row, but it's true that it generates a lot of side effects, all of them reversible, but you have to take that into account when recommending the product to the patient, for sure.
There's another question, Paula, which is which kind of essential oils do you recommend? We haven't specified that during the presentation, but we have the investigation refers always to the combination of 4 essential oils that are included in the formulations under the brand name Listerine in Europe. In the United States, there are some other formulations, but the 4 essential oils that are formulated in Listerine.
And they are asking us for the clear indication of mouthwashes for prevention, which is something that we said, but just trying to be clear, they are not recommended on a general basis for gingivitis prevention, as it has not been evaluated in that objective, but they are indicated for the prevention of periodontitis in the assumption of the continuum of the same disease that periodontitis and gingivitis represent, and for sure in the prevention of recurrence of periodontitis.
Yeah, that's another question about acute conditions. And acute conditions, whenever you are planning a short-term use, a very restricted use, for example, after surgery, or when you have necrotizing gingivitis, the ideal agent is chlorhexidine, because even if will have sun staining, the limited time of use will make these side effects acceptable. And when there's another, and this question and another one about using that in irrigators, and the thing is that the studies do not see much differences when you do irrigation with and without antiseptic agents. So it seems that the delivery format in the irrigations will not sustain the antiseptic effect. So water will do more or less the same.
And there's a question related to the recommendation of toothpastes or gels with chlorhexidine for the daily use, which is the best format, and if they always have to be added to the mechanical plug control, and that for sure is a yes. You always have to provide the best level of mechanical plug control, both if you are thinking about the professional part of the treatment or the daily personal basis, but always as an adjunctive to the mechanical plug removal. And whether it is better to use the toothpaste or the gel, it depends on the agent that you are analyzing, because not all the products work the same in all the formats. So, for example, with chlorhexidine, it's true that there are different brands with different formats in the market, but not all of them are the same, and not all of them have been combined. So it would be difficult to give you a specific answer for that. But probably my answer would be that the best format would be mouthwashes, which is the easiest way to formulate the chlorhexidine, and the best results have been published with that format.
There's another very interesting question about the equilibrium in the oral microbiome, and that the impact of these antiseptic agents is not that huge. And actually, it is tested. So in these randomized clinical trials that I have mentioned, there is an analysis, microbiological analysis, and of course, there are some positive effects, but they are limited. So overgrowth of opportunistic species or other dramatic changes are not there. But there are some studies some years ago that suggest that they may alter the metabolisms of the nitrite and nitrate, and that will induce some changes in the microbiome that could lead to, for example, high risk of suffering high blood pressure. All these studies are now trying to be replicated. We don't have the evidence yet, but it's something that is under evaluation. and additional information will come soon, I hope.
They are also asking about the use of triclosan, which is something that you mentioned, that it has been removed from the market due to the environmental concerns related to it. It was effective for sure, but you cannot find it any longer. I don't know if it's only in the European market. I don't know if it's available in other places.
Triclosan is still in the market even in toothpaste and some products, but it is slowly disappearing. But the best well-known toothpaste with triclosan is not in the market anymore. I don't think it's everywhere in the world. So slowly it will disappear. But remember that triclosan was also in shampoos, in gels, everywhere. It was everywhere. It still is, but they're slowly disappearing.
And something that they are asking, and I would like to translate to ask you the same, is because you know everything about pastes, and is the ones with hyaluronic acid. Do you know if there's any research behind them?
Well, the research is being conducted. I haven't seen convincing results yet. Of course, the objective is a little bit different to what we are saying today. This is more to promote healing and not to control gingival inflammation. So what I have seen is promising, but I could not foresee if there will be something that will change practice.
And there's another question about something that we have debated before, which is the differences in substantivity, and if this has any impact on the effect of the different agents. And in fact, not for sure. I mean, it's true that chlorhexidine has the longest substantivity and it's very effective, but it's not. What happens is not the same as with antibiotics, and you have to adjust the dosage depending on the substantivity. In this case, for sure, there will come a moment in which the antiseptic is not working, but that's not a problem. The time that it works, and that's fine. So there's no problem if it's longer or shorter, the substantivity.
Yeah, and that's another very interesting question by Dr. Bravo about the natural extract that could be used as antiseptics. And so far, the evidence that we have is very limited. So there's probably no reason right now. But for the future, there's a tendency to use products that are most compatible with the host. And coming back to the previous question about the microbiome, so we want to live together with our microbiome in peace, let's say. So using antiseptics or antibiotics at the end is throwing bombs to our microbiome that is part of our body too. Is as part of our body as our hands or our skin. Therefore, there's a tendency to move to other products that may be antimicrobial or not, that may be more, let's say, natural or maybe more respectful with the microbiome. It's a tendency we will see. For the time being. We don't have anything that replaces these antiseptic agents, but in the future, who will know? I think it is very interesting, this approach and this research approach.
I don't know if there's anything left.
I think we have tried to, first thing, thank you very much for all the questions. It's amazing the amount of questions we have made, not being able to answer all of them, but I'm really happy to receive so many questions. I hope we have tried to answer most of them. And also, I'm very happy to see the audience. So I could not do that at the beginning. I thank first Kenvue, then I thank SEPA and also Paula for inviting me to be here. And now I thank all of you for all the questions and for attending this session. Thanks a lot.
Thank you. I will reiterate your thank you, and I will thank everybody for having stayed with us until these times that I don't know in your countries, but here in Spain is more or less time for lunch. And I hope we have the chance to meet personally, at least for the people here near us. We'll find the time to meet in Bilbao, where we will have our Congress, where SEPA's National Congress. So I promise I will answer those questions that you still have on your minds and you have not had the time to write them down. And thank you very much for your attention, for Kenvue's opportunity to be in here, and for sure for you, David, for having spent this hour with me. Thank you so much.